Good morning, everyone. So today I'll be taking again the same refractive errors. So last week we studied about the optics, the basics of the optics, and today we'll be studying about the refractive errors. So refractive errors is not a diseases. So it is it doesn't come under diseases. So don't think it is any abnormal. So refractive errors today we'll be studying in detail. So before going for the refractive errors, so we have to know some terms. So first of all, we know what is emmetropia, because in later classes we will be talking about what is emmetropia. So many times the term will be used. So you should know what is emmetropia. So it is defined as the normal state of refraction in which the parallel rays of light from infinity are focused on the light sensitive layer of the retina when accommodation is at rest. This means the rays from infinity, they are focused on the retina, means which is a normal state. So there is no refractive error. Here the patient will have a 6/6 vision, means it is an optically normal eye. So means the parallel rays are focused on the retina. So it is considered as the normal, what we call as the emmetropia. So at birth, the eyeball usually everybody you know at birth the eyeball will be short. Means the axial length will be shorter. So the every person will have about +2 to 3 diopters of hypermetropia. So this gradually reduces by the age of 5 to 7 years, and the eye becomes emmetropic till the age of 50 years. So it will start at birth. The eye is hypermetropic at birth, but gradually reduces by the age of 5 to 7 years, and the eye becomes emmetropic till the age of 50 years. Afterwards, after the 50 years, some people will develop again hypermetropic state. So that we call as the refractive state, refractive error. So you should remember here at birth the eyeball is short, and everybody will have +2 to 3 diopters of hypermetropia, which gradually reduces by the age of 5 to 7 years. Then the eye will become an emmetropic state, means it is a normal condition till the age of 50 years. But some people will again develop a hypermetropic state. That's a refractive state, refractive error state. So that you have to always remember. So emmetropia is a normal refractive state. There is no error. So you can see the diagram. So you can see the parallel rays of light. You can see this is the parallel rays of light. They are focused on the retina. So here this is the retina. So they are focused. This is the parallel rays of light from infinity. They are focused in the light sensitive layer of the retina. When accommodation is at rest, means when eye is rest, the rays are focused on the retina. So what we call as the emmetropia. So this is the very important. You have to know these things. Next, we'll go for the ametropia. So what do you mean by ametropia? Ametropia is a refractive error. So here you have to mention ametropia means it is a refractive error in which the parallel rays of light from infinity, they get focused in front of the light sensitive layer of the retina, whether it is front or behind, or sometimes they do not come to one focal point but form two focal lines when accommodation is at rest. So here you have to remember ametropia is nothing but a refractive error. So refractive error, it can be a myopia. If the rays fall in front of the retina, we call as myopia. If the rays are falling behind the retina, we call as hypermetropia. Or sometimes the rays will not come to one focal point, but they form two focal lines. This is what we call as the astigmatism. So if it goes in front, it is myopia. If the rays is going behind the retina, it is hypermetropia. If they do not come to one focal point, they should converge and form one focal point, but it is not coming. It forms a two focal lines. So this we call it as the astigmatic state. So ametropia can be a myopia, hypermetropia, or astigmatism. So this you have to remember. Now we'll go detail about myopia. So we'll study one by about myopia. So very important for the examination point, because many times you'll be asked the questions about myopia, and many people, many people in your this thing also more are myopic. So you want to know what is the myopia, and we'll study about in detail. So myopia is a refractive error. In the layman term, we call as the short-sightedness. So it is a refractive error. So first of all, it is a refractive error in which the parallel rays of light from infinity, because we don't know where the rays are coming, so we call as infinity. They are focused in front of the light sensitive layer of the retina when accommodation is at rest. So many times it will be asked for the definition. So you have to tell complete definition. Means it is a refractive error. First of all, the first point is a refractive error in which parallel rays. So whenever you're seeing a distant object, so your rays will be parallel, and those rays we don't know where it is coming, so we call as infinity. So the parallel rays of light from infinity, they are focused in front of the light sensitive layer of the retina when accommodation is at rest. So this is a very important point you have to note. The accommodation is at rest means the eye is at a relaxed state. So when accommodation is rest, the rays are focused in front of the retina, the patient will have a myopic state. This is a diagram you can make out here. This is a parallel rays of these are the parallel rays of light from infinity. They are focusing here in front. So this is a retina, but here it is not falling on the retina. It is focusing in front of the retina. So this is a myopic refraction state. So the rays are falling in front of the retina. Instead of going on the retina, it is falling in front of the retina. So we call as the myopic state. Now, what is the classification? How do you classify myopia? So myopia can be classified according to the what we call it is not a clinical classification. We call as the different type of classification. So depending upon the eyeball size or the curvature of the eye or the refractive index, so we classify into axial myopia. So what is axial myopia? The name itself tells it is the axial length, means the anterior posterior diameter of the eye. Based on that, we classify as axial myopia. So here, which is the very commonest type we call. So it mainly results from increase in the anterior posterior length of the eyeball. See, normally the anterior posterior diameter of the eye is about 24 millimeters. But here in this type of myopia, the anterior posterior diameter may be increased, or the eye may be elongated. So usually you see in young patients. So young patients, we usually see this type of myopia. That is the axial myopia, where the axial length of the eyeball increases. So that is the axial myopia. Curvatural myopia. So next is it is the name itself, the curvature. Curvature may be due to the increase in the curvature of the cornea or the lens, or sometimes both. So if there is increase in the curvature of the lens, or the cornea, sometimes both the curvature is increased. For example, you in keratoconus. So keratoconus, I have already taken the chapter. Keratoconus, there is increase in the curvature of the cornea. So there we call as the keratoconus. Sometimes if there is increase in the curvature of the lens, so we call as lenticonus. So in those conditions, we see a curvatural myopia. So curvatural myopia is seen in some diseases. Remember, it is seen in some diseases like keratoconus or lenticonus. Next, we will come to index myopia. So the name, again, we can make out the name index, means it is a refractive index. Refractive index of the mainly from the lens, crystalline lens. That is a natural lens what we have in our eye. So there is increase in the refractive index of the lens. So usually this type of myopia usually we see in senile cataracts, means patients who is having cataract, especially nuclear sclerosis. So you see the index type of myopia, where the refractive index of the nucleus becomes more. Normally, the refractive index, I think in the basic anatomy, if you have studied in the lens chapter, the refractive index will be approximately about 1.39 to 1.4 or 1.1. So the nucleus will be different. So here the nucleus, the refractive index is approximately we call as 1.40. So here the refractive index becomes more, especially the nucleus. So the patient will develop a nuclear sclerosis. Usually seen diabetics, mainly commonly seen in diabetic people. So this type of index myopia. So this is elderly patients. Remember, patient who's walking in, he has got a cataract, and you do refraction, it is showing -3 diopters or -4 diopters of myopia. Don't think it is some axial or curvature. It is mainly because of the lens. That is because of cataract, the refractive index of the nucleus has been increased. So he has developed the index myopia. So you have to remember, which is usually seen in aged people, that is in senile cataracts. Sometimes we also get a positional myopia. So what is positional? The name again is mainly due to position. Sometimes there may be a lens may be anteriorly placed, or sometimes you put the IOL. For example, patient has undergone some cataract surgery. For some reasons, you could not place the lens in the bag, the capsular bag. You have put it in the sulcus, or you have placed the IOL in front. So that will induce the myopia, what we call as the positional myopia or consecutive myopia. So that we call as the occurs due to anterior placement of the lens, whether it is a natural lens, if it is displaced in front, so due to some reasons, or sometimes due to intraocular lens also, which is placed anteriorly. So that also will induce a positional myopia, what we call as the consecutive myopia. And sometimes you can also see myopia due to excessive accommodation seen, which is seen in patients with some spasm of accommodation. We see in patients some excess of accommodation. You will be seen in spasm of accommodation. So that type of also myopia can be seen. So in general, you see so many types. So one is axial length myopia, that is the axial myopia, curvatural myopia, index myopia, positional myopia, and myopia due to excessive use of accommodation, which is mainly seen in patients with spasm of accommodation. So that is a very commonest condition again. So that is the 5 broad classification, and we go for the etiological, again the clinical classification. So that was the etiological. There was some reason, but here in clinically, how do you classify? So when you are seeing a patient, we classify this is a simple myopia, this is a high myopia, this is congenital myopia, or this is a pathological myopia. So clinically, how do you classify? So we can classify broadly into congenital myopia and acquired myopia. In acquired, we have a simple myopia or pathological myopia. So this is a very simple classification of clinical classification. Now we will go for the congenital myopia. So congenital myopia usually seen the name it is present since birth, and it is frequently seen in premature babies, babies who are born early to the gestation period. So they usually see patient, those patients will be having a congenital myopia, and usually diagnosed by the age of 2 to 3 years. So 2-3 years, you cannot diagnose when the baby is born, newborn, so you cannot diagnose, very difficult. So usually the diagnosis will be the 2 to 3 years age group. And usually most of the time it is unilateral and manifest as anisometropia, means one eye will be normal, other eye will have a myopic state. So that we call as the anisometropia. Anisometropia in later classes, I will describe in detail. So anisometropia means one eye will be normal. Means, for example, one eye is emmetropic, the other may be myopic. So we call as anisometria. Most of the congenital myopia will present like an anisometropia. And the error will be, the starting error will be up to 8 to 10 diopters, and it may remain constant. It may not progress also. And the child will have a convergent squint in order to clear at its far point. So for the far point means the farthest object which we see clearly is called as the far point. So the child will develop a convergent squint in order to clear at its far point, which is about 10 to 12 meters, centimeters. So here you see there is increase in the anterior posterior diameter of the eye, that is the axial length, and sometimes it is usually associated with other congenital abnormalities like congenital cataracts. It may be a microphthalmus, aniridia, Marfan syndrome, or homocystinuria, megalocornea, congenital separation of the retina. So many conditions the child will be having associated. So it is not only congenital cataract, myopia will be there. Associations also will be there in some children, like cataract, microphthalmus, aniridia, Marfan syndrome, etc. And how to diagnose? So diagnosis usually done by retinoscopy. There is no other, no lab investigation, nothing. You have to do a retinoscopy and estimate the refraction. You can come to know whether the child is myopic and what is the refractive power. Means what is the power of the myopia? So this has to be done with full cycloplegia. Means we use the drops, cyclopentolate drops or atropine, any cycloplegics. Most commonly what we use is the atropine, because the child will have a strong accommodation. So you have to paralyze the accommodation and do the refraction, because if you do refraction in the accommodative state, you will get all wrong readings. So because the child will be exerting accommodation, which is very, very strong in younger age group. So you have to paralyze the accommodation by using cycloplegics, especially atropine 1% eye ointment is advised. Before doing this refraction, you have to ask the mother to put the atropine eye ointment 1% twice a day for 3 days. Then after that only you have to do refraction and calculate the power, which the calculations and all, which will in the practicals we can demonstrate and see. So there you estimate the power. So that diagnosis is mainly by doing the retinoscopy under complete cycloplegia. So this should be your diagnosis, and the treatment is you have to prescribe the line of treatment, that is this. So your spectacles is the main line of treatment. So you have to prescribe the concave lenses. So here your myopia is corrected with the concave lenses. So appropriate power you have calculated by doing a retinoscopy. So you know the power and give the prescription of the glasses with the help of the concave lenses. The suitable power is corrected. And the full correction, usually in children, we always give a full correction. And if it is not corrected, for example, the myopia which is not detected early, and if it is not corrected in a younger age group, the patient may go for amblyopia, means the lazy eye, and they may develop squint also, which is a very bad situations for the patient itself, because in future also it is a lifelong, like actually when they develop amblyopia, there is no correct treatment is available. And squint, because it becomes a lazy eye and the eye will turn outwards or inwards, whatever it is. So the child will have a cosmetic problem, and the vision also will not improve. So all these problems will exist. So early diagnosis and early prescription of the glasses is the most important line of treatment, especially in refractive errors. And so in children, so better correct the early age group. Prescription is given with the help of the concave lenses. So this is about congenital myopia. Now we'll go for the simple myopia. So what is simple myopia, or it is also called as the developmental myopia. So developmental myopia, again, it is the commonest, usually acquired age. You means after the birth, it is usually seen, especially at the age of the prevalence. We see the incidence rate. The rate is about 2% at the age of 5 years. You see, or 14% at the age of 15 years, or sometimes it will occur between the age of 8 to 12 years of age. So that is why we call a school myopia, because it increases 2%, very less in a 5 years age group. See, and 14% at the age of 15 years. And then you take 12 years, you can detect this type of myopia. So we call it developmental myopia or simple myopia. So what is the cause for this myopia? It is not some physiological error which is not associated with any. So here you see there is no disease at all. There is no associations. The patient will be a simple myopia, simple refractive error with no associations, means with no disease of the other. It's a physiological error we call. So what is the physiological, this thing will come to the etiology now. So it results from the normal biological variation. So the simple myopia, it results from the normal biological variations in the development of the eye. So here, what is the role? They tell the correct etiology is not known. It is just a predisposing variable. Role of genetics also will play an important role in what is the genetics, means what is the hereditary factor, why it is hereditary factors, how the so sometimes we tell if both parents are myopic, for example, both parents are having a myopic refractive error, there's 20% of the chances the child also will be getting in future. So we assume that 20% of the chances will be affected. If one parent is myopic, for example, one of the parent is myopic, so there are 10% of the chances. Or if the parents are not myopic, there is only 5%, very less. So we tell a role of genetics, means hereditary factor, where sometimes we tell both parents are myopic, there are chances about 20%. If one parent is myopic, only 10%. If no parent is myopic, means parents are not myopic, but the child will having only a 5% of developing myopia in future. And they tell if you do excessive near work, there are chances of getting myopia. So we don't know how much it is. There is a theory. It is just it is not a correct factor for developing myopia. So they tell. And sometimes there may be associated factors like as I told you in etiological classification, axial myopia. There may be increase in there may be increase in the type of the length of the eyeball, or the curvature may be due to underdevelopment of the eyeball. Sometimes the role of diet also, the role of the diet is also main factor for the development of the myopia. So sometimes the role of diet is also, they tell if you eat more of green vegetables, carrots and all those things. But how far it is true, we don't know. It's just they tell it is one of the cause. If you eat the less this thing, people will tell you get myopia. It's not fine. It is not true. So don't think that if you eat proper vegetables, you will not get myopia. It is not true. Okay. So these are some of the causes for the myopia. So you know the simple myopia, it is mainly a normal physiological variation, maybe due to some genetic factors. So now we'll go for the what is the optics in myopia? What happens in simple myopia? What happens to the optics? So here you know the far point is in front of the retina. Means we have defined the myopia. Means the rays are falling in front of the retina. That we call as the far point. And you know the emmetropica, the far point is at infinity because we don't know where the rays are coming. So we call as infinity. And the higher myopia, the shorter distance. And if a far point is kept at 1 meter distance, the myopia will be, so whatever the far point is situated. For example, if the far point is at 1 meter distance, then myopia will be about 1 diopter. And the nodal point is always further away from the retina. So here in patients with this myopic, especially the accommodation, they do not exert more of accommodation. So they result in convergence insufficiency. So here, what is the reason for why they develop a convergence insufficiency? Because the accommodation will not develop normally, because they'll be using more of accommodation, and the accommodation process will not exert more. So which normally develops is not there. So the patient will have a convergence insufficiency, and they may later develop, it may be a latent exophoria or exotropia. Tropia means a manifest, phoria means a latent. So optics in myopia, you have to remember the far point is in front of the retina. So if the far point is kept at 1 meter distance, the patient will have one diopter of myopia. And because the nodal point is farther away from the retina, the accommodation will not develop normally. So the patient will develop a condition called the convergence insufficiency. So later they may go for the exophoria or exotropia squint type of squint. So what are the clinical features? So we know the classification, we studied about the etiological causes, and we'll know what are the clinical features, how do they present. So the presentation, I think you know, it is mainly they come with diminution of vision for the distance. So they will have a difficulty in seeing object for the distance. So defective vision for the distance mainly. And they will have sometimes asthenopic symptoms like eye strain, headache, fatigue, and they feel sometimes they tell whenever I read, I get watering, photophobia, all those things are asthenopic symptoms. And especially you see in low myopics, means the power which is very low power, lesser power, due to dissociation between the convergent and accommodation. See, convergent and accommodation will go together. So there is a dissociation between the convergence and accommodation. So patient will exert more sometimes accommodation and convergence insufficiency. So they will have eye strain, headache, all this problem will start. That especially in low myopes. And they also may develop convergence weakness and exophoria and suppression of eye. So if they are using more of convergence, they may develop, I told, convergence insufficiency or a weakness. The later there are chances of the patient may develop the exophoria or the suppression. Means they may have constant usage of one eye and the other eye which is not used. There will be suppression. The patient may go for amblyopia and squint also. What are the signs? So sometimes in this type of myopics, you see myopic patients, they will have a slightly a bigger size eyeball. This means the anterior posterior diameter of the eye is more. So they will have a size of the eyeball will be big, very prominent. You can make it from far. If some people they have a very prominent eyeballs, we tell so maybe a myopic this thing condition. So they have a prominent eyeball. So eyeball will appear larger in size and anterior chamber is slightly deeper than the normal. So you can, whenever you examine, the anterior chamber appears slightly deeper and pupils will be mid-dilated and sluggishly reactive to light. So some of the myopics will have all these clinical signs. The eyeball size will be bigger, prominent eyeballs we call, anterior chamber may be slightly deeper and pupil will be slightly mid-dilated. So normally we have pupil size, but here you can see sometimes 5 or 6, so which is not an abnormal. So whenever you see that type of pupil with prominent eyeballs, we tell it is a myopic state because patients, and it is not any abnormal thing. So mid-dilated and sluggishly reactive to light and fundus most of the times in simple myopia, it will be normal. Very rarely we see any this thing myopic degeneration. So almost it will be normal. And usually you see in this type of simple myopics, the error will not be, exceed more than 6 diopters. So anything which goes more than 6 diopters, we call as high myopia. Anything which is less than 6 diopters, it is a low myopia. So it is not called as the high myopia. So patient, the power will be lesser only, less than 6 diopters. And as usual, so as I told you in congenital myopia, the diagnosis is confirmed by retinoscopy, and you have to always do a cycloplegic refraction, especially in myopics for the first time if they are coming. Now we'll go for this thing pathological type. As the name itself tells, the pathology means some abnormality is there. So it is otherwise called as the progressive type of myopia because it will be progressing very fast. It is degenerative because the degeneration in the retina, vitreous, choroid, everything will be there. Degenerative changes will appear. Malignant myopia, since it is very rapid growth. So we
Shut up, man.
hello.
Ma'am, your microphone is muted. Sorry, ma'am, reason due to connectivity issues. Punya S. Vasan. Punya Vasan. Class ஒரு பொண்ணோட பேரு
Tell me.
புண்ணியம்.
Hello. Any problem in listening?
Kumar.
Can you hear me? Hello. Hello. There's some disturbance going on. Hello. 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 Is it okay? Can you hear me? Hello. Shall I continue or stop? Hello. Okay. So pathological myopia, it is otherwise called as the progressive myopia or malignant myopia. There are so many names are there, and it is a rapidly progressive error because see, it usually from childhood at the age of 5 to 10 years and results in appearing earlier that when it start in the age of 10 years, there may be a -6 diopters. When he develops the adult, this thing early adult, for example, at 24 years, the myopia would have increased about 10 to 12 diopters. It is very rapidly progressing. Without when it is progressing, they will have what changes in the retina. That it is called degenerative myopia. So what is the etiology in pathological myopia? So mainly due to the rapid axial growth of the the eyeball, which is outside the normal biological variation. So, two important factors here, which is the role of growth factor and the genetic factor, means the hereditary factor. So, what is the growth factor? Some people will grow very fast. Outside the normal biological variation, there is a rapid growth of the eyeball. So, it may be due to the role of hereditary also, sometimes familial. Very commonly like Arabs and Jews also. Some group of people will have this type of pathological myopia. And I told the role of general growth process. As the growth process is a lengthening of the axial diameter, which may lead to progression of myopia. So it is also a minor role. So two important factors. One, role of hereditary factors. The next is factor. So two important for the development of myopia. So what is the genetic factors plays an important major role. So factors, so there is retina, there is a stretching of the sclera. Same thing, the process will you see in the growth factor also, because as the body grows, the eyeball size also increases. There is more growth of the changes within that. So this is a diagram. You can see the diagram. The comparison. This is the normal this thing. You can see the line which is shown. This thing. There is so much elongated, so much the increase in the size, the axial length of the eyeball. So elongation of the eyeball posterior to equator in pathology. So much is there. This is the equator, line and line for the equator. So you can see the posterior part from here, the posterior part of the equator. So there is so much elongation of the eyeball. So this is the line for the equator, which we have seen pathological myopia. So what are the clinical features? So usually the main symptoms, the patient will have a very bad vision here. Means the very poor vision. We don't call bad vision, sorry, a poor vision, because they will have too high power. So they'll be so poor, centimeters if they have very high. So they really come to the vision, degeneration of the vitreous, black thing that is particles. So what we call the muscae volitans. Muscae volitans is nothing but some floaters. So they complain of floaters. Something is moving in front of the eye, black opacities, mainly because there is a degenerative changes which are occurring in the vitreous. So muscae volitans means some floaters, black when you move, when you right side or left side, the opacities also will move. So this is mainly because of the degeneration in the vitreous. So muscae volitans. The next complaint will have a night blindness. But night blindness because there is a degeneration of the photoreceptors, mainly the rods of the patient will have a night. What are the signs when you see this type of patients, especially patients who have a very high power ectopic? Same thing, they will have very prominent eyeballs. Eyeball appears to be like a proptosed. You see a proptosis patient, the eyeball will like bulging. So both sides bilateral proptosis appearance. So, but this is not a true proptosis. It looks like a proptosis. The maybe due to high myopia, it will simulate like a proptosis, but it is not a true proptosis. It is a pseudo-proptosis. We call it this pseudo-proptosis. So you have to find that high myopia is no proptosis. So sometimes they simulate exophthalmos, means like a thyroid. You have seen the thyroid, bilateral proptosis, it will appear like that. So don't hear it. Also, cornea appears very bigger in size, and tear chamber becomes deeper, and the pupil appears mid-dilated, sluggishly reactive to light. And the very important thing, the fundus examination is very, very important. And most of the times will be asked in exam. Fundus, you have to write a diagram and show. So fundus picture in myopia, always it's very important. You have to know how to write the diagram. I'll show you the images also. So first of all, when you write the fundus optic disc, we come to the optic disc. So optic disc is always nasal to the nasal side. So macula will be always temporal, whereas the optic disc will be in the nasal side. So the optic disc will appear larger in size. So it is not, what is the normal size of the optics is usually 1.5 to 1.5 diameter. So here it becomes more, the diameter also will increase. It is large and like long myopia, and it appears sometimes like, although sometimes appears like a tilted. So optic disc appears to be tilted. So that we call as the tilted disc. Means optic disc appears larger in size. It may appear oval in face, and it is also called as the tilted disc. And commonly we see the temporal crescent, mainly temporal crescent, temporal side of the optic disc, that is in the macular side, commonly seen, and sometimes crescent and may extend around the disc, what we call as the annular crescent. So when it extends all around the disc, we call it the annular crescent. And in some cases, there may be a supertraction of the crescent. Means, what is the meaning of supertraction? Means the retina is pulled over the retina due to traction, because it's thinned out, so it will pull. So the retina is pulled near over the disc margin, so we get a supertraction of the crescent. So you see a temporal crescent. Normally you see a temporal crescent in the myopic fundus, and this crescent may extend all around the disc, what we call as the annular, or sometimes there may be a supertraction over the disc margin. So that we call it. The normal cup ratio will be usually 0.2 to 3, the normal. Sometimes it may go for 0.4 also. So in myopics, the disc ratio will be 0.4, 0.5, 0.6 also. So don't confuse it for the glaucomatous cupping. So always differential diagnosis you have to make whenever you see any bigger size cupping. Normally, sometimes you see 0.5 cupping and you diagnose as glaucoma. No, it is not correct. So you have to see the other signs of glaucomas. In glaucoma, I think already covered some. How do you identify the fundus changes in glaucoma? So you have to know how to differentiate a myopic cupping and the glaucomatous cupping. So in myopia, except the cup disc ratio size, the cup disc ratio size, there is no other abnormalities. So, but in glaucoma, you see bionetin signs, many other signs are there. But here, only the cup disc ratio is more, we call it the myopic cupping. And there you can see a peripapillary atrophy on the temporal side of the disc. Sometimes you can see the spontaneous ruptures in the Brooks membrane, which is known as the Lecker's cracks. Lecker's cracks is nothing but the spontaneous ruptures in the Brooks membrane, which is known as the Lecker cracks. You can also see sometimes a small hemorrhages may also develop within the Lecker cracks. And these Lecker cracks may dispose to macular chorioretinal new vessels formation. So there may be a new vessels formation, what we call is the chorioneovascularization. So it is a chorioretinal neovascularization. So new vessels will start developing with these Lecker cracks. So these are the spontaneous ruptures in the Brooks membrane. Sometimes you can see hemorrhages because of these Lecker cracks, and there may be predisposition of the new vessels, what we call the chorioretinal new. Later there may be formation of chorioretinal neovascular membrane also. There may be, in the later stages, there may be a membrane formation also, which again may lead to retinal detachment in some conditions. In some people, you can see a Foster-Fuchs spot. So what is this Foster-Fuchs spot? It is nothing but a dark red circular patch. See the macula due to subretinal neovascularization and the choroidal hemorrhage. So Foster-Fuchs spot is nothing but a dark circular patch which is seen in the macula, mainly because of the choroidal hemorrhage or due to subretinal neovascularization and due to choroidal hemorrhage. You can also see some degenerative changes in the retina, what we call the cystoid degeneration. It may be seen in the periphery of the retina. In some advanced cases of the myopia, very high myopics, there may be a diffuse chorioretinal atrophic patches causing patchy lesions leading to macular myopathy. So it's a very dangerous this thing, because when patient has developed atrophic patches in the region, the vision will be very badly affected. So the patient will not get any improvement with the vision, whatever you do, any refractive surgery, whatever you retinal atrophic patches, sometimes they may involve the macular area, causing the macular. There may be a lattice degeneration, which is again the common retinal degeneration you see. And in patients with myopia, 8 to 10% general population, they will have lattice degeneration. Means the people have pathological myopia, 8 to 10% of the people will have this lattice degeneration, which is a very main cause for the retinal detachment. About 20 to 40% of the people will develop retinal detachment. Very common in the moderate myopes, moderate to high myopes. This so it is usually seen in the equator and the ora serrata, means in the superior temporal. Mainly why it is occurring, because it is mainly due to discontinuity in the retinal layers. There are 10 layers. So internal limiting membrane is one of the layers. So there is a discontinuity. So the patient may develop the lattice degeneration. Later in future may develop the retinal detachment. And in advanced cases, you can see all the layers of the retina, that is the inner layers of the retina, will be atrophied. So that is why we call it the high myopia. It is a degenerative myopia. So the degeneration takes place in all the layers of the retina. So this is the fundus picture of the pathological myopia I'm showing. You can see this is the optic disc, what we call is the round optic disc. And see, that's usually this. It is a lesser size. You can see the disc size is enlarged, and optic disc also. The optic disc cannot be made out. This is a very big. So, and you can see the foster fuchs, which is a circular red patch, which is seen mainly because of the subretinal new vessels. And you can see these are the ruptures, whitish, what you are seeing. These are the ruptures in the Brooks membrane, what we call the lacquer. So the cracks are seen usually. So this, so optic disc is enlarged, myopic cupping is not made out because of the so much pallor is this thing is there. So there is a pale and the temporal. This is the pale and temporal crescent, which is again extending circularly, and you can see the lacquer cracks, the whitish, what you can see this here, and you can also see the foster fuchs. What we hear. So this is the picture of pathological, and some cases you can also see posterior staphylomas. So again, this will be asked in the exam. What is posterior staphylomas? Where do you see? So posterior staphylomas is usually seen in pathological myopia, mainly because of the ectasia of the sclera. Means so there is a thinning of the sclera because the eyeball size is increasing. There is a stretching of the retina. So when the retina is stretching, the sclera is also stretched, and sclera becomes thinned out. So sclera becomes thinned out at the posterior pole and may be appears like an excavation with the vessels bending backwards over the margin. I'll show you the image. So this is a typical picture of the. You can see the posterior staphyloma. So mainly due to ectasia of the posterior part of the sclera. So you can see like an excavation on the vessels, how the vessels are bending backwards over its margins. It is the vessels are running over that. You can make out the vessels are going above this thing. So this is the typical picture of the posterior staphyloma, which is mainly because of the ectasia or thinning of the sclera you see in very high myopes. So again, you see all this chorioretinal degenerative changes, everything you see. This is a very classical picture of the posterior staphyloma. again, after the retina, the changes also will be seen in the vitreous. So in the vitreous, you can see vitreous. Usually, it will be a gel form, but it undergoes a liquefaction because it will become very much liquefied. So you can see a vitreous opacities, and there may be a posterior vitreous detachment, which will appear as a vis reflex. So sometimes, what is vis reflex? It will be asked. It is nothing but the posterior vitreous detachment, like a vis reflex. So there may be changes in the vitreous also in the form of vitreous becomes liquefied, there may be vitreous opacities, or there may be a posterior vitreous detachment. And if you do visual fields, perimetry in this type of patient, means because there is so much degeneration has occurred in the rods, so the constriction of the field, there is a ring scotoma, what we call the ring scotoma, which is usually seen in high myopes. So the peripheral part will be full. There is a scotoma. The patient will develop a scrotal, central vision also will be affected. Central means macular region. So visual fields show the contraction, and in very high myopes you can see a ring physiological, electrophysiological test like ERG, electroretinography. If you do electroretinography, you can see the subnormal electroretinogram due to chorioretinal atrophy. So the choroid is also atrophied, the retina is also atrophied. Because of the inner posterior segment of the structures will be involved in high myopia. That is the reason why patient will develop poor vision. So ERG, if you do ERG in this very high myopes or pathological myopes, you can see the in the form electroretinogram. So it may be due to chorioretinal atrophy. So what are the complications if you don't treat the myopics in the early period? So there are chances of these patients going for retinal detachments. Why? Because of the lattice degeneration. The retina, there may be a hole, so there may be a cracks in the retina, so which will cause the detachment. So retinal detachments or posterior vitreous detachment is also very common. Patients may develop a complicated cataract type, vitreous hemorrhage, there may be a choroidal hemorrhage, there may be a macular hole also because of the maculopathy, this thing, and they develop a strabismus fixes convergence. They will have a convergence insufficiency. So that we call as strabismus fixes convergence. And these patients are more prone to develop open angle type of glaucoma, or they have pigment only normal tensive glaucoma. So the patients also, they tend to develop glaucoma, which is open angle type, mainly pigmentary type or normal tensive glaucoma. So how the diagnosis is made? So diagnosis mainly made. So you have to do a retinoscopy. So retinoscopy is a confirmation of this thing, high myopes. So you can do a retinoscopy. As I said, the earlier thing, cycloplegic, and you can do some other additional test. You want to see whether patient has got poor vision. Suddenly, you don't know, you have done retinoscopy, but why so much poor vision? So you can do a B scan, so to know that patient has developed any retinal detachments or posterior vitreous detachments. So always in high to know whether patient has developed the retinal detachments or the posterior vitreous detachment or the posterior staphyloma. So sometimes we do OCT, ocular coherence imaging technique. So you membrane, chorioretinal neovascular, chorioretinal neovascular membrane, or sometimes you can also see the macular hole also. By doing OCT, you can confirm the diagnosis. So main important, the diagnostic part is you have to do retinoscopy, then the additional like B scan to know whether the patient has developed retinal detachment or PVD or posterior staphyloma. You can also do mainly method study to retinal neovascular membrane to see all those things you can. The next class I'll be discussing about the treatment aspect. Thank you. Fifth class start.